Flatfoot is a disorder that involves multiple joints in the foot, but also the knee, hip, and potentially spine due to the change in static condition of the leg axis. A key element of the static changes in a flatfoot pathology is a hyper-eversion of the calcaneus with a medial drop of the sustentaculum tali, combined with an anterior translation of the talus over the calcaneus. The talus loses its plantar support and plantar flexes. The talotibiofibular unit performs an inward rotation relative to the axis of the body. The knee is forced into abduction and the valgus position, while the hip moves into abduction. Due to the plantar flexation and relative inward rotation of the talus over the calcaneus, the talon-avicular joint hyperextends with a talonavicular joint uncoverage. The forefoot performs an abduction and pronation relative to the longitudinal foot axis. Important medial stabilizers are the deltoid ligament and the spring ligament. These are involved in the pathology because of either elongation or tearing. On the lateral side, a relative approximation of the lateral talar process and the anterior calcaneus process can be noticed due to the eversion of the calcaneus and anterior translation of the talus. The ProStop Subtalar Arthroereisis implant functions as a free-floating splint in the sinus tarsi. It prevents the approximation of the two processes of the talus and calcaneus, correcting the anterior translation of the talus over the calcaneus. Simultaneously, it forces the calcaneus out of hyper-eversion, positioning it back in its physiological position under the talus. As a result, it also facilitates the relocation of the talus in its physiological position above the calcaneus. The surgical technique to implant a ProStop Subtalar Arthroereisis implant is simple and straightforward. A skin incision is made in the soft spot of the sinus tarsi, just proximal to the anterior process of the calcaneus. Blunt dissection of the subcutaneous tissue is carried out with the hemostat. The dissection of the interosseous ligament is not necessary for this procedure. A blunt guide wire is inserted in the sinus tarsi and advanced through the tarsal canal. This wire passes approximately 15 to 30 degrees off the perpendicular to the sagittal plane, going from anterolateral to posteromedial. This direction aims for the sustentaculum tali. The guide wire tends the skin medially. If desired, a small medial skin incision can be made to allow the passage of the guide wire through the skin. Secure the wire with a clamp. The wire will exit below the posterior tibial tendon. The trial sizers are used to determine the appropriate size. The shafts of the trial sizers are marked with a laser-marked scale to measure the depth of the sizer. For most patients, the correct placement can be assumed when the 20 mm laser mark reaches the skin. It is mandatory to screw the trial sizer in and out and not to pull it out. This is to prevent injury of soft tissue, such as the interosseous ligament, which plays a major part in holding the final implant in place. After each trial insertion, the alignment and derotation of the calcaneus under the talus is checked manually. If too much eversion is present, the diameter of the trial sizer is increased. An AP fluoro shot is used to confirm the correct placement. The calcaneo-cuboid joint line is used to confirm the correct AP X-ray trajectory. If the joint line is not clearly visible, rotate the foot until the joint line is clearly visible. Otherwise, a rotated image could give a false impression of the implant or sizer position. The implant should not be medial to the midline of the talar neck. After the appropriate implant size has been assessed, the respective sized implant is loaded on the driver. The implant is inserted in the same fashion as the trial sizers. Keeping the foot everted while disengaging the screwdriver helps to prevent unintentional pull-out while removing the driver. The K-wire is removed. An eversion of the foot may support the removal of the K-wire as the medial narrow part of the tarsal canal opens in eversion. The final placement is checked with fluoroscopy. During bodyweight load to the foot, the ProStop Subtalar Arthroereisis implant prevents the eversion of the calcaneus and anterior translation and plantar flexion drop of the talus. If the ProStop Subtalar Arthroereisis implant needs to be removed, the instrumentation facilitates this procedure. After skin incision and blunt dissection, slide the blunt guide wire into the implant. The funnel-shaped opening helps to locate the cannulation in the implant. Use the driver to unscrew the implant. If the implant is turning idly without moving towards the skin incision, the ProStop Arthroereisis extraction tamp can help to push the implant from medial. Advance the K-wire to medial and incise where it tends the skin. Slide the extraction tamp from medial over the guide wire and push the implant while turning it counterclockwise with the driver.